We'll be presenting today on trauma disorders and trauma treatment approaches. I did adapt the slides from this presentation from previous presentations by ASAP's Dr. Fernandez and Dr. Lindsay, as well as Meg Shuttleworth from UNM's Pain Management Center. So our objectives today are that at the end of the presentation, you'll be able to identify key characteristics that differentiate stressful events from traumatic ones, describe hallmark characteristics of common trauma reactions, typical course of recovery from trauma, and the major signs and symptoms of a stress disorder. Identify, describe, and apply components of trauma treatment and treatment recommendations for patients with trauma exposure, and then describe strategies for utilizing the information provided in this training in order to be able to apply it to everyday clinical practice. So we'll start by differentiating stress from trauma. This certainly gets used interchangeably, both colloquially and sometimes clinically, and it is important to differentiate them because for one thing, it's important for selecting the appropriate intervention, but also sometimes when patients mix up stress and trauma, it can either be invalidating for them or it can cause them to pathologize essentially the stress of everyday life, which doesn't help them either. So we'll look at that a little more closely now. What is the stress of everyday life versus pathological stress? So looking at this performance curve versus stress level, you'll notice that on the far green side, there is very much such a thing as not enough stress. So if you're in that green zone, you're really not motivated to take care of the tasks of everyday life. So that's what we consider not quite enough stress, is just not being able to get things done because you're not motivated enough. The ideal level of stress, so that's what we would consider good stress, is that yellow zone. So that's where we have enough stress that we're motivated to do what's important to us in life, but not so much that we're overwhelmed. If the stress is too much, or if our capacity to sustain it is inadequate, that's when we tip over into that orange zone of exhaustion, where it's not that motivation is a problem, it's that we're just too exhausted to effectively manage the tasks. And then if that goes on for too long, that's when it can lead to that red zone of anxiety, panic, anger, and eventually breakdown. And that mirrors that green side in that you're not able to address the tasks of everyday life, not because you're not motivated, but simply because you just don't have enough resources left to address them. So when people spend too much time or just the intensity of that red zone is too much, that's when stress can become pathological. But it is important to remember that there is such a thing as good stress, and that we're not trying to entirely get rid of stress for anybody. We're just trying to manage stress to make sure that it stays in or close to that yellow zone. So looking a little bit more at stress, let's get the animations in here. Stressors do occur throughout life. They're a necessary factor in the development of resilience and functionality. So again, we're not going to get enough done if we don't have a little bit of stress. And also if we don't have a bit of stress, early on in life, then we don't build up the resources to deal with it later. There's some interesting child studies showing that a moderate amount of stress early on in the context of a secure attachment relationship actually conditions the hippocampus to be more resilient to future stress. And you can easily picture this in a more tangible way when we think of patients who, we probably don't see too many of these patients, but who have not faced a lot of adversity in their life. And then when something traumatic or very stressful happens, once they're in adulthood, they haven't developed those coping mechanisms, whereas sometimes people who have had a moderate amount of stress or exposure to trauma along the way, they've built up some of those resources. So we do have that innate ability to adapt and cope with stress, and our responses to stress are going to vary by a number of factors, most prominently the intensity of the stressor, our individual history, so that includes that prior experience with stress and stressful events and whether it has taught us anything about how to cope effectively with them. Our coping style, particularly whether our coping style is active or passive and how that contributes to resilience. And then our available supports, and that means both the internal supports, so having a lot to do with coping mechanisms, and then our external supports, because we do know that the psychosocial environment and how supportive it is a really significant factor in our stress-related outcomes. So this is what's called the general adaptation model, and it helps us to conceptualize a little more directly what's happening during stressful events and the different pathways it can take. So you'll notice the first dip off the homeostatic baseline, that's a stressor. It's helpful to remember that stressors can be experienced as positive or negative. So threatening stressor could be losing a job, exhilarating stressor could be starting a new job you're really excited about. Either way, your functioning is likely to dip a little bit because you are going to be pretty stressed, or there's a lot of stress in your system rather. Then the most likely response is the alarm response, which means that your body is going to kind of step up to the occasion, galvanize your resources, and that's going to allow you to sort of overperform. So you sort of have a surplus above the homeostatic baseline. So you might have experienced that, those are those instances where you have almost like a sort of mild hypomania, where you get to sleep a little less, but get more done. You're very focused, you're very on task. That usually doesn't last too long before the body steps in and says, we only have so many resources. They put a little friction into the system to downregulate you back towards the homeostatic baseline. And ideally, you're only going to dip below that homeostatic baseline very briefly, if at all. So that's when you hopefully can draw on some resiliency and you're able to get back up to baseline. What can happen if either the internal or the external resources are insufficient, or if the stress is too prolonged or severe, is that arrow keeps plunging downward from exhaustion, and that's where it leads to pathology and potentially even morbidity. So remembering again that the sort of natural course is to return to the homeostatic baseline, and that it's really only if the internal or external resources are insufficient or if the stressor is too intense that the arrow keeps going downward. So in terms of addressing stress interventions, remembering most people are going to return to baseline quickly if it's an acute event, meaning a single short episode. It's when the events are chronic that it becomes more likely to be a problem. So that's when the body's alarm system is continuously activated, and that takes a very heavy toll on our mind and our body. So that's likely to require intervention. That could be medication, therapy, lifestyle changes, really a number of sort of micro and macro interventions. Our individual ability to accommodate to chronic stress does vary significantly according to the intensity and the frequency of the stressor, as well as, again, our internal and external resources. This is important to emphasize, I think, for our population, because most of the patients that the providers here see are operating within this sort of web of ongoing psychosocial stressors. Very often these are these kind of chronic, continuously unfolding events that are taxing their system and are making it harder for that arrow to go back up to baseline and making it more likely to go downward if intervention is not offered. So we'll turn now to trauma as we continue to differentiate between stress and trauma. And I want to preface the DSM-5 definition of trauma by saying I imagine most providers here have had the experience of meeting with a patient who feels that they have experienced a trauma even though it does not meet these criteria. And of course, it's not helpful to invalidate them by saying, no, sorry, the DSM-5 says you actually didn't experience a trauma. What can be helpful is to distinguish, this is what the DSM says trauma is, and that helps us to find the effective intervention, but that doesn't mean that what you experienced was not traumatic. And that can be a really important distinction for patients to understand. So in terms of that, what's the criterion A for PTSD is a person being exposed to actual or threatened death, serious injury, or sexual violation from one of the following specific scenarios. It's either directly experiencing the traumatic event, witnessing it in person, and then these last two are much less common. So that's learning of the violent, actual, or threatened death of close family members, specifically with very vivid details. And that's a really important caveat. So it doesn't happen too often. The very difficult to contemplate example here is that a parent sees a crime scene report from a child's violent death, and that would have enough really close details in it that mentally they're going to be reconstructing that event as though they were there. And then lastly, also much less commonly, experiencing repeated or extreme exposure to aversive details of a traumatic event. And it doesn't count if it's just through popular media, unless it's related to your work. So this is almost exclusively a presentation of people who work, for example, as first responders or in the military, where they're just constantly saturated in very grisly details of a traumatic episode. So looking again at stress versus trauma as we start pivoting to trauma, remembering that trauma indicates a specific and extreme type of stressful events. So that means that traumatic events are stressful events, but not necessarily vice versa. So it's that unidirectional arrow. And again, that's part of the psychoeducation we can offer to patients about what is the stress of everyday life? What is too much stress in everyday life? And what is a trauma? Because different interventions are going to work for different points on that arrow. So looking at types of trauma, the broad categories here are shock versus strain. A shock trauma is an acute trauma, single event, short duration, high intensity. The example would be stranger assault. So that's definitively acute. It's a single event, limited time. The other large category is strain. So that's multiple events, long duration, and less intensity, which sounds odd perhaps, but the idea is that it's perceived as less intense because the person has habituated to it. So an example might be domestic violence, where the first episode would be a shock trauma, but then once it's happened 11 or 12 times, it's perceived as being less intense because of the habituation. It becomes a strain trauma. The subcategories within strain traumas are chronic versus complex. Chronic is just what it sounds like, multiple events over a long period of time. Complex is a much more specific type that has to do with multiple events during childhood that are specifically caused by caregivers. So there's a really defining attachment dimension to a complex strain trauma. And we'll talk more about that in a bit with diagnosis. So in terms of trauma during childhood versus adulthood, both the nature and the chronicity of the trauma, as we've mentioned, will impact both the response and the etiological pathways. Adult events generally have a less detrimental impact on the system, although again, if it's a chronic traumatization and re-traumatization without intervention, then it is much more likely to lead to a pathological state. Unfortunately, childhood events, children are just so much more vulnerable to long-term outcomes from traumatic events, and particularly those strain traumas. It is likely to have significant and long-lasting impacts on neurodevelopment specifically. So just a couple examples out of a multitude of examples are that adverse childhood events significantly increase the risk of mood disorders in adulthood, and they actually both mediate and moderate pain disorders in adulthood. So you can kind of see just how far-flung the downstream effects are for children who grow up from having childhood trauma. So looking more closely at ACEs specifically, that's adverse childhood events, you have the event as the foundation of the pyramid here. That leads to disrupted neurodevelopment, which we'll look at more closely in a moment. That in turn is likely to lead to social, emotional, and cognitive impairment, which in turn gives rise to a greater likelihood of adopting both high risk and health risk behaviors. That, of course, leads to a much greater susceptibility to disease, disability, and social problems. And this is all compounded in a much higher rate of early death. You can see with the upslope and the downslope arrows that there are epigenetic mechanisms through which ACEs actually activate that kind of diathesis stress component, so that underlying vulnerabilities that may have remained undisturbed in a life with less stress or trauma become activated and can even contribute to genetic changes, which are then passed on to the next generation, genetically, behaviorally, and then also, as you see with the downslope arrow, through intergenerational transmission that could also be community-based trauma. So there are many levels at which even just a single person experiencing several of those adverse childhood experiences accumulates in the system. So we'll look a bit more closely at neurodevelopmental effects. This is still a very big picture approach, but can be helpful for psychoeducation. And that's to say that traumatic events can and often do directly impact the function and the structure of the brain, primarily through stress hormones. There's the activation of the neurochemical almost cascade that leads to a lot of physiological and psychological symptoms downstream. So in the acute phase or in the acute instance, the alarm system in the brain is activated. So that's what we call the HPA axis. That's the hypothalamus, pituitary, and amygdala, the adrenal system that controls that fight, flight, freeze response. And then under chronic conditions, that's when it's most likely to lead to a disordered response where there are significant and sustained neuroendocrine system changes associated with structural changes. And this, of course, it depends on a patient's level of medical literacy, how much you might get into this with a patient, but I do find it's very often, at the very least, to contextualize for patients that exposure to trauma really can, at a very fundamental level, change the way that their brain works, because that can be very validating to people who are experiencing that but don't realize it. And a metaphor that's used in a lot of different types of PTSD therapies is this idea that you have the alarm system in your brain. It's okay if it goes off for a little while when something dangerous is actually happening. That's a good thing. But if it gets stuck on, just as if, you know, the smoke alarm in your house is malfunctioning, it's very difficult to relax, to get just the tasks of everyday life done. And of course, you're going to be hypervigilant if you have that alarm system blaring all the time. So in terms of responses to trauma, individually, there are a number of dimensions that are going to affect the response. The type, as we discussed, how proximal the patient was to the event. Previous trauma, as we discussed, could be that they have built resilience or that they have been depleted. The relationship to the perpetrator, a significant difference between a stranger versus a known person. Coping skills and vulnerability, again, that's the internal and external resources. Importantly, the response of the support system. As I mentioned before, that psychosocial context is a really important ingredient in recovery. And what we see with communities who have experienced quite a lot of violence, where there's sort of community level trauma, is there can be this sort of defensive cynicism where the individual is seeking support, but they're being invalidated with responses like, well, that happens to everyone, or that's not that bad, or other people have it worse, which of course is not generally helpful. Also, the level of life stressors at the time of the trauma, so including were things going great, or were there already a lot of difficulties that they were facing, and then the perception of the event. So that last one is the level at which cognitive therapy seeks to intervene. Interestingly, one of the strongest predictors of the actual development of PTSD is if the traumatic incident was an incident of sexual violation. And the theory behind that is that socially, we have a lot of embedded messages about what it means to be a survivor of a sexual assault. So there's a lot more sort of perceptual layers to that. So it can be helpful to think of PTSD as a disorder of non-recovery, because that helps us to remember that actually, by far, the default is actually natural recovery. So close to 80% of all adults have experienced at least one trauma in their life, and the vast majority of them, around 70%, are going to recover without any need for intervention, just with time, psychosocial support. So that's called natural recovery. That's one of several reasons that PTSD can't even be diagnosed until at least a month out from the traumatic event, because we would expect, and it is healthy for people to be experiencing short-term symptoms that correspond to the PTSD criteria. So that's what we would think of as a temporary drop in homeostasis, but then that they do, the arrow goes back up and they can restore and adapt. So remembering short-term, really everybody exposed to trauma is likely to have some of those symptoms, and that's a good thing. That's an adaptive response. It's when that response is sustained, when it becomes long-term, that it's disordered, and that's going to occur in roughly 3 to 10% of individuals, and as previously noted, is going to vary significantly by disorder and gender. So thinking of how we classify trauma disorders, usually the first one we're going to think of in the context of the DSM is PTSD. And then of course, ASD is the short-term under 1 month reaction. But what we often don't consider as providers is that there are a number of other disorders that may be precipitated by trauma, but are not strictly classified as trauma disorders. However, they very much functionally are part of the sequela of the trauma. So most commonly that includes mood disorders, to a lesser degree obsessive compulsive disorder, and then very prominently sleep disorders and substance use disorders. I imagine most of the providers here have witnessed that themselves, that there's quite a lot of overlap there. So this can be really helpful, particularly to validate patients who have experienced something traumatic but do not meet criteria for PTSD. And sometimes that can feel very invalidating for them, but being able to explain, because overwhelmingly, most often, they are going to meet criteria for one of these others, usually a mood disorder. And being able to explain, it's not about the DSM saying your trauma wasn't big enough. It's really just about your individual response to this trauma. And in this case, the outcome was, for example, a mood disorder. So diagnostically, again, very important to look at the timeline of events. If there is that temporal precedence where none of these symptoms were present, trauma occurred, then for example, a mood disorder symptoms have presented, then that gives us a hint. It's unlikely to be constitutional and maybe proceeding from a traumatic event. I do want to mention, even though it's not in the DSM-5, it's very relevant to our population. a term that is endorsed by the National Center for Traumatic Stress, which is complex trauma. And that's thinking back to what we talked about earlier between strain and shock trauma. Complex trauma is when a child has experienced ongoing abuse or neglect at the hands of a caregiver. So there's that attachment injury. And the presentation includes dysfunction and dysregulation in interpersonal functioning, identity disturbances, mood dysregulation. So it looks a lot like borderline, but it's not borderline, right? So we're expecting that this is going to be in the next edition of the DSM. In the meantime, a very important clinical consideration to keep in mind with our population, because it very often pops up, these people who look like they have borderline with a little bit of ADHD, and it is in fact a result of complex trauma. I do want to just quickly note some of the symptom overlap here. When we look at the criterion B features for PTSD, there is so much overlap with depressive and anxiety disorders as well as substance use disorders. This is part of what makes those differentials really difficult. So when we consider what the prevalence rates are, sometimes we'll see a traumatic event in a patient history and we leap to PTSD. That's actually the lowest prevalence rate as far as what is likely to proceed from a traumatic event. More likely that people are going to end up with a depressive disorder, an anxiety disorder, or a substance use disorder. But of course, there's a lot of overlap in the symptoms. So that's on the one hand, a reminder not to overdiagnose it, because sometimes we see the traumatic event and immediately think PTSD and forget that there's so much natural recovery as well as other etiological pathways. And then just to make things complicated, reminding you it can also go in the opposite direction, which is to say that sometimes if a traumatic event is not overtly obvious in a patient history, or if a provider overlooks it, then patients end up with several sort of like a constellation of different diagnoses that actually could be unified under PTSD when you look at the symptom overlap relative to the onset of the trauma. And remembering that a lot of people are ashamed and prefer not to share about, especially traumas associated with a lot of stigma, such as childhood sexual abuse. So this is Bessel van der Kolk pointing out people are often being treated for 3 to 8 separate co-occurring disorders without appreciating of the contribution of trauma. A quick note about evidence-based treatments as we look at how to treat PTSD. EBTs are treatment that are found to be efficacious and effective in multiple well-controlled studies. That means treatment, no treatment control groups, random assignment, valid and reliable measures, and that the integrity of the treatment is checked and replicated. So these are very sturdy treatments that have been very well reviewed. CBT is the sort of overarching umbrella here. That's, the main philosophical system of CBT is looking at the interlinking of thoughts, behaviors, and emotions, and acting primarily on thoughts and behaviors in order to change emotions. They are established as empirically valid treatments. And under this umbrella is included exposure procedures, anxiety management, and cognitive procedures. The goals in this case for PTSD have to do with promoting safe re-experiencing and modification of dysfunctional cognitions that underlie PTSD. So a treatment that is not a standalone full treatment, but is an important preface or preamble to standalone treatment is anxiety management. And that's just the set of techniques that help to reduce system arousal. So examples would be Seeking Safety or PTSD 101, and it's a pretty low intensity, mostly psychoeducational and slightly experiential series in which patients learn things like controlled breathing, relaxation, positive self-talk. And these are things that are going to help fortify them in order to handle the relative intensity of a standalone PTSD treatment. So exposure therapy, specifically prolonged exposure, is a gold standard treatment for PTSD. It's very expressly behavioral. The ultimate goal is to allow patients to approach rather than avoid feared stimuli. And it's composed of a set of techniques that help them engage with those objects, situations, memories, and image that have provoked a lot of fear in them because of the traumatic incident. So examples would be systematic desensitization and flooding. In terms of cognitive therapies, that's just a collection of techniques used to identify and change the cognitions that are dysfunctional or erroneous that are related to the trauma. And those include directly challenging the thoughts. So an example would be through Socratic questioning, and then also purposefully replacing those cognitions with more adaptive ones. So looking at the EBTs for PTSD, cognitive processing therapy and prolonged exposure are the gold standard. CPT is available in group format as well. More recently, EMDR and ACT for PTSD have been endorsed by some, but not all of the major organizations that, that provide reviews for evidence-based treatment. And then you'll just notice, thinking back to the symptom overlap, that there is a lot of repetition here between PTSD and MDD and anxiety disorder treatments. You'll see acceptance and commitment therapy shows up in all of them, CBT shows up in all of them. And then thinking about, importantly for our population, this longstanding fallacy, which I think people now recognize or are beginning to recognize as an anachronism. There's this idea that people need to abstain from substance use before they can participate in PTSD treatment, and that is not the case. In fact, there's overwhelming evidence that the treatments go very well together in tandem rather than consecutively. And a lot of harm can be done if we do try to insist, as has been done in the past, that people complete substance use disorder treatment before they start PTSD treatment. I think it's understandable the concern, because PTSD treatment can be very intense and can be very stressful. But as long as both treatments are being provided, are EBTs and are being provided at the standard of care, then they're actually going to complement each other, and they're going to get more bang for your buck out of both of them. So, for example, prolonged exposure specifically has received the Exemplary Substance Abuse Prevention Program Award from SAMHSA, and it was selected as a model program for national dissemination. So remembering, they're not just incompatible, they're very, very compatible, and they very much should be used together. All right, I know that was really fast. Let me zoom out here, check the chat, and see if you all have any questions.